very good evening to everyone. On behalf of Voice of Healthcare and Beatrice, I welcome both the speakers and the attendees for the very first episode of this talk show series, that is Breast Cancer Awareness, series of virtual dialogues. This series of discussions have been curated in collaboration with Beatrice to mark the ongoing Breast Cancer Awareness Month, that is October 2021. For this episode, I have with me two very eminent speakers whom I'd like to just introduce. Sir is Dr. Narayanankutty Warrier. Sir is the Medical Director at MVR Cancer Center and Research Institute. Sir is one of the most well-known oncologists from India who has nearly 3 decades of experience in cancer treatment and is also the member of American Society of Clinical Oncology. I have with me Dr. Shubnum Singh. Ma'am is the Principal Advisor of Healthcare in Confederation of Indian Industry, CII. Ma'am has been with us since years now. And without further ado, I'd just like to hand it over to Dr. Shubnum to take the discussion forward. Ma'am, over to you. Thanks.
Thank you, Khushbu, and good evening, sir, Dr. Warrior, and all colleagues who have joined in today. As always, I compliment Voice of Healthcare in bringing up a diverse set of topics which are very relevant and contextual in nature for healthcare, and then they continue to be persistent in developing the right set of conversations, I would say, with a wide network to not only make people aware, but also to participate in changing what is something very uh, is so close to everybody's heart, and that is how does it impact me and how is it that I can help in the process instead of always saying somebody else should do it. So I'm absolutely delighted to be part of this talk series. And when we look at the topic that breast cancer and increasing healthcare burden, desired policies to bridge treatment awareness and gap. Dr. Kuti, when I looked and I done a little bit of research and been associated with some of the reports, white papers, and recommendations given, when you look at this piece and have seen how the needle has moved over the years, definitely a lot of work, good work has been done, both in the private sector as well as in the public sector. I mean, one cannot deny it. From a zero platform or a minus platform, we have definitely moved. Yet, like with all other diseases, this gap between the urban and the rural piece just doesn't seem to get sorted out. It just doesn't. And the same applies to breast cancer. So, with that as a starting point, would you like to share some insights as to why this gap happens? If we can understand the why, then we can work on the how and what to do. Please. Over to you, sir.
Dr. Shubnum Singh, thank you so much for this invitation. Actually, the topic is of immense interest. I have been hearing this for the last 2 decades. People telling that we don't have that many mammogram machines, and also we don't have that much resource for screening people in India. And whenever it comes to the early detection of breast cancer, mammography is an integral part of that approach, the 3 methods. And this was the main hindrance, or this was the main concern of all the people concerned. So we don't have that many resources, we don't have that many machines, human resources as well as machines to screen people when you consider mass screen. But I feel that we are somewhat successful in bringing down the stage at which the diagnosis is made at least in the urban area, because of the major awareness created through various platforms like the print media, social media, and continuous awareness talks by health workers like me. So that has really helped in bringing down the stage at which the breast cancer is diagnosed, the diagnosis is made. But unfortunately, the rural area, it is still in the very backward situation. Like you won't get many in that early stage. The reason being they are not at all aware and they don't have any access to these mammography machines, and they don't have any planned or any well established ways of doing screening. So my suggestion is we should be having different approaches to urban and rural areas. So the urban area, I think we should continue with the screening methods, mass screening, and people are aware of the early detection methods of early detection. So they are keen on utilizing either in the private or in the public facility, and they should be motivated to get these tests done. But in the rural area, we cannot apply the same principle. Instead, we have a very good system of ASHA workers in the grassroots level. So these ASHA workers are very good. Some of them are excellent in their approaches, and they are very friendly with the rural women. So, health education through ASHA workers is the main key of it should be the main key in our approach, and we can train them. In fact, way back in 2012 in Kerala, where I am coming from, Kerala, you cannot apply this rural and urban difference, but still. We have that those days we don't have that many mammography machines. So what we have done was we have educated this. We have adopted a village, adopted a panchayat, and the ASHA workers were given training how to ask questions. It's basically a questionnaire method, and we have taught the ASHA workers the symptoms of breast cancer, and then we shortly. Then even we taught them how to examine breast. These ASHA workers were motivated, and they were given incentives to go to the public, the women, and they were screened by using ASHA workers. And then subsequently, when they shortlisted people, we will be going with our force like a mammography man and plus the doctors and or the other paramedical staff, so that these women will be subjected to mammogram and then subsequent detection of cancer. There are a lot of pitfalls in the method. I do agree with that, but at the moment we cannot apply a mass screening for all patients, all persons, not patients, all persons. At least this should be the approach. There are several advantages for this particular concept. The one is when you teach all the ASHA workers, and they in turn they teach all the women of say one particular ward where at least 1,000 population will be there. So out of which, if you think that 50% will be women, you can roughly you can make out you can figure out about 500 women. So this 500 women will be taught how to examine the breast. At least they will be taught about the self-examination of breast, plus the warning signs of breast cancer, and in case if required, they will be subjected for mammography. So subsequent years, even if this program is not running, they will be motivated. They will be educated about the warning signs of breast cancer. Plus, they will be keen to have a mammography done whenever there is a doubt arises. So these are some of the advantages. Coming to the urban population, I told you we can definitely apply mass screening program, and they will be going for annual checkup, and where probably we can give some incentives. And the Indian people are very happy if they get something free of cost. So but when it comes to the health, they, even if you are doing it for free of cost, they will not come. So, what I should suggest is you can even say in the ration shop, if you show them the evidence of having done a mammogram, then they can get 1 kg sugar free of cost. So that should be the incentive, or that sort of an incentive based, and so that they will be motivated, because there is a drastic change nowadays. The family, women are the head of the family as per the government. So the ration cards are in the name of women. So definitely you can say that if the family wants to get 1 kg sugar extra, they have to show that a mammogram is done, and the mammogram can be arranged at cost by coordinating all the resources in the urban area. But the rural area, definitely this will not work. So there, yeah, we have to go by the route which I have mentioned. So over to Shubnam. What are your views? What are on
I
my suggestion?
No, I think this is brilliant. And honestly speaking, as I was saying a little earlier, if you look at the grid of anything, as far as health is concerned, on the platform of accessibility, affordability, etc., the grid throws up pretty much the same challenges for everybody. And the approach to it, I have to say, with a hand to my heart, the government has tried very hard. It's not as if state governments as well as the center have not put their shoulder to the wheel, and the ICMR. But the challenges, I think, lie, which you pointed out very rightly, in rural India at the level of engagement. I think that was a brilliant point, that in the level of, for rural India, the challenge of being able to have diagnostics to support, right? And I believe there's a huge opportunity in how to move the needle of diagnostics, but the level of engagement that the ASHA worker can have, that approach will work very well. And perhaps, and you're right, when I was like the statistics that show on an average, if the median is 6.1 weeks in our in our geographic, in the Asia Pacific region, that it takes about 6.1 weeks for a person to know that they have breast cancer. So they have the symptoms by the time they get diagnosed, and they come to the first point of treatment is 6.1 weeks. And in India, we're sitting at 4.7 weeks. So we're not that far off the median, if I were to say. But the situation in rural India definitely pulls us back. And I think this part of motivation of an incentivization in urban areas is also an extremely interesting piece. There was another statistic, Dr. Warrior, on the same lines, that the incidence, for instance, in Delhi of breast cancer was 41 per 1 lakh, 100,000, followed by Chennai, which was 37.9. Bangalore was at 34.1, and in Trivandrum it was 38.7. So, what do you think is, again, does this speak to that engagement awareness piece, or are there anything other that is underlying for these differences?
There are differences. Why I'm telling is there is an argument that these areas are more people are more educated, more aware of their health problems, and they are more aware about the methods of early detection, and that could be the reason why we get high incidence. Actually, that is one argument. But in practice or in experience, in our own experience, we find that there is tremendous increase in incidence of breast cancer. There is no doubt about it. You may be having good detection centers, where you may be having good opportunities, good facilities for early detection, everything. But if you look at they are not really early stage disease. There is a definite increase in incidence of breast cancer, and on an average, probably the national average will be 30 out of 1 lakh population, 1 lakh women. But this is 1 lakh population. But basically, there are some centers where there are some areas where you can expect even 47 out of 1 lakh population. So it used to be 15 out of 1 lakh, and sometimes it was 20, 25. Now it is going up. And in Kerala, we have about 300 times more compared to a decade earlier. There are definitely the incidence is more now, and I can tell you various reasons for that. But before that, we must say that the breast cancer is increasing in the incidence. It's not merely the reporting of breast cancer. There are definite reasons for that, and that we must accept it.
So, when you mention the various reasons, right? Uh, Very often we try to blame everything on our genes, right? So, in and also in the treatment protocol of breast cancer, the matching of the treatment, like earlier and today with her coming in, her two, etc., this becomes even more important. So, what is your viewpoint on the narrative of the genetic story in breast cancer?
Oh, that's very impressive now. Earlier we used to say that the breast cancer is not a hereditary condition; it's only less than 5%. But as science expands, we see that there is a 25% of all breast cancers are found to have some gene defect, like the BRCA1 and 2, and more variants of these genetic abnormalities are being detected. So I feel that uh, breast cancer, at least 30 to 40% will be genetic origin, and the 60% will be somewhat other causes. About other causes, basically, this is a hormone dependent cancer. So, uh, any reason where you find there is a market fluctuation in the hormones will have a propensity to develop breast cancer. So definitely the hereditary or the genetic alterations one side. The second part is the hormonal fluctuations, and these hormonal fluctuations are probably mediated through various other factors like your lifestyle factors. And in the true sense, it is not a lifestyle disease, but still there are some lifestyle which can influence your genes as well as your hormones. So uh, these hormones, these lifestyle changes, that includes even the diet. That is why urban people are more prone for breast cancer. High That is why we get high incidence of breast cancer. And I told you that in Kerala we don't have any urban-rural difference. So the affluence is comparatively higher in Kerala, where the women have higher uh, or have they can get the good food. They are all the access to good food and good living conditions are more with in Kerala women. So that could be one of the reasons why they develop breast cancer. Access to good living condition. What I meant is it's basically an affluent society, so that they take more fatty food. They do less exercise. Their physical activity is less. All these indirectly contributing towards the development of breast cancer, and also the children are getting menarche earlier, and the women are getting menopause late. So that is one of the reasons, the main reasons why we are having high number of breast cancer in India. So Kerala women, there is a tremendous shift from their life cycle. There's a tremendous shift compared to the previous decades. So more and more, the earlier they get menarche and the later they get menopause, there is almost 15 years of extra exposure of hormones the body has to face, and that could be the reasons of high incidence of breast cancer. And of course,
Breast.
as Shubnum said, the genetics, genetical factors, the genes definitely play a part, but these factors are working through these genes. So these are the some of the reasons why we get more incidence of breast cancer.
So I think some exceedingly important and interesting points that you brought up, and that is related to the diet. Is there any merit in saying that fortified foods? We all know hormones are used in the dairy industry widely to increase the production of milk, right? Uh, is it worthwhile looking at what is happening in that industry? To your point that menarche is coming earlier and menopause is getting delayed, and therefore this window of exposure to high levels of hormones is there. So, is there a merit in saying yes, we now need to relook at the usage of these in the industry as far as foods are concerned?
Yeah, Shukla, but this is totally different. The reason is I know that there are empty number of fortification things in the diet, and and all our teenagers are very happy to eat all this junk food, and many times we blame junk food for all this. But actually, this fortification or what in the form of hormones given orally will not have that much impact. But definitely, oral contraceptive pills are, especially the estrogen containing pills, are having an impact on breast cancer. So, long term use of oral contraceptive pills are definitely not good for breast health. So similarly, I don't know whether you can correlate with the hormones in the diet. That we don't know. But in fact, the early onset of menarche is related to several factors. One is they are all fed with fatty food. Our children are getting more fatty food now. Secondly, they are not playing. I generally tell I generally explain this in all my awareness classes. Our teenage our children are not able to play what they used to play in or what we used to play in our childhood. Yeah, you may be remembering that we will be running and we will be doing a lot of activities, the playing which requires physical activity. Now, girls are not getting any opportunity because of several reasons, and they are getting fatty food. So one end you are getting fat like anything, and second and you are not playing anything, you are not burning your calories. So that and the fat deposition in the body is more. where this fat is notorious to store hormones. So the whatever the hormone produced in the body will be stored in the fat cells, and that causes the fluctuation, and they become they get menarche earlier, and that is one of the reasons. And also superadded with a lot of mental stress. So fatty food, less physical activity, coupled with mental stress, causing our girls to get menarche by age 8 or 9. It's same reason for the late menopause. Like they are stressed. Women have a dual role. They have to work as well as they have to manage home. So they are stressed. Both stress will be on the women, and because of the affluence, they all get all sort of they are not doing physical activity that much,
Right. So
especially.
it just perpetuates the whole thing. It
Okay,
goes
yeah,
into a
I'm
cycle.
not blaming the system or any that in that way. I think one should not take up my words. What I'm saying is, the people used to walk to the bus stop, or people used to walk to get into the office, which is not happening because nowadays you have facility to straight into the parking lot, and from there to lift, and without doing any physical activity. So that sort of a life, and very fast life. Plus, after hearing all this, the women should not be blaming me, telling that whatever the facility we have, you are jealous about our and
Yeah.
equality and all. But do consider this as one of the important points in developing the breast cancer.
In our health. That's very important. And COVID hasn't helped with everybody being housebound and physical activity as it is coming down. So I'll just shift tracks a bit. That over the years, from 2010, 2011 onwards, a lot of work has been done, as I said, from the central level. So we have the National Cancer Grid, we have National Registry, we have the NCPCS, NPCPCS, and in which it's mandated that screening for women over the age of 30 takes place for breast, cervical, and other cancers. Now, when we use the word mandation, right, on the floor level and the implementation level, just by mandating something does not necessarily mean that it will happen. It's not necessarily it will happen. What do you think is required more than just saying it's mandated that you have to be screened for this?
Yeah, it's basically the any rule cannot help you bring or help any administration to bring masses into mammography machine. It will not happen unless people are motivated, unless people understand the importance of doing this procedure, this test, and what will happen if they are diagnosed late in the course of disease. All these matters a lot. So unless we educate people about the importance of early detection, for example, if you do a regular mammogram every year, women above 40 years, if they do a regular mammogram every year, once a year, then they will be able to detect abnormalities which have not even caused a lump in the breast. So the surgeon or the oncologist get the advantage of treating a breast cancer which is detected at the mammographic level. So there won't be any mutilating surgeries. There won't be any chemotherapy. Sometimes you can safely avoid chemotherapy, or sometimes even You don't have to do the mastectomy, and the cost of treatment will come down drastically. So these advantages should be highlighted, and and it should be taught to the public so that people will be motivated. But what we see is a lot of stigma is still attached to cancer. So because of this, people are even not coming for an awareness class. And I'm sure our discussion, I don't think that many will be watching that, but unfortunately that is the scenario. So even the word cancer causes lot of fear in the audience. So they are reluctant to come for a screening program or even for a class. How will you avoid this, or how will you change this society's mind? You can definitely can change the mind, but because this we have seen with other specialties. Say, for example, people were very reluctant to detect sugar because they say if we detect sugar, then we will not be able to eat sugar containing foods. Then we will not be able to take any sweets. So I don't want to get diagnosed diabetes because then after that I cannot eat the sweets. This is what the mentality used to be. But now they, even when the small wound it is not getting healed, even after 3 or 4 days they go and check blood sugar. So that sort of a motivation and that sort of an awareness should come. Then only this will be under control. So for that, I think there are the various ways. One is definitely you give for the urban women the social media and other strategies will help. The rural, you have to give some incentives so that they will be motivated.
No, you're absolutely right. And I was going to, as I said, the grid is the same and the challenge is the same. So whether earlier it was with diabetes, we are still struggling with tuberculosis and working in corporate India for this TB Bharat initiative. And this is what we also found: the social impact is so huge that they don't come forward. They don't even access treatment for fear of what it's going to mean from a financial perspective. And there comes my next question. Uh, Treatment, diagnosis is hugely expensive, right? We lack oncologists, we lack access to, especially if you have a metastatic breast cancer, you cannot afford that kind of treatment. The insurance companies are limited in their coverage of this. I think Ayushman Bharat is doing a good job. It's trying to make things happen, but then it gets hampered with the lack of infrastructure and the lack of availability of medication, so on and so forth. So, what would be your message to, or what would be your recommendation for a policy to look at as to how do you fund this piece? It's brilliant that we have all these guidelines, ICMR, registries, uh, mandation of getting screening done. But from availability of resources to be able to access that screening, right? So I've got screen, I know I have this problem, now what? Where do I get the money to move forward? What would your thoughts be on that or your recommendations on that piece?
See, basically we have a lot of resources. Financially, you cannot say that we don't have resources to establish mammography machines. Only thing is, and also there are a lot of NGOs working in this scenario, and they don't have someone to guide them properly, and what I feel is we used to have a very good program running under the name of National Cancer Control Program. So the central government has this National Cancer Control Program, and with all its activities implemented through the district administration. So let us say National Control Cancer Control Program, or there's a central team, and policies are implemented through the district administration. So under district administration, there should be a group of whoever is interested in conducting these programs. So there are a lot of NGOs, and there are different hospitals. So you can say because the cancer, this can be detected early, breast cancer should be given the priority. And we know that the commonest cancer in the Indian women is now breast cancer. So we have to allocate budget for that. And so through this National Cancer Control Program, through the district administration, and the district administration should entrust, at least make sure that all the hospitals, district hospital, taluk hospital should be having a mammography machine. And the private hospitals and the private mammogram units that can be utilized with the help of NGOs. And you can very well say that the whatever you are charging for the private hospital, private patients, this persons coming through this program should be charged, or that there should be a cap in for charging when you are sending patients or persons through this program. So because the number their number will be more, so the hospitals will be able to offer at a lower price. And there should be some targets given to all these ASHA workers and other people at the grassroots level, so that these things will be done with that. So there should be a coordination at the district administration level. There should be a coordination of the various NGOs working in this scenario, and they should be recognized properly so that other NGOs will be interested. Something like that. There should be some motivation to the NGOs. Say an NGO which has done 1,000 mammograms last year should be given some recognition at the national level. So that sort of a thing.
Okay. So again, it is the engagement, and you're saying the governance process for this should be at the level of the district administrator. So within the interest of time, seeing that I've got 1 minute left, the last question is that on capacity building and the lack of oncologists, and we know for a fact that the gap is just too huge for every speciality. Is there any way in which we can ramp this up in a shorter span of time by going through a method of recognition of prior learning of doctors, especially for tier 2, tier 3, as well as in rural India, because the oncologists are not going to go there. I mean, you're short of them in cities. Where will they extend themselves there? And even if we leverage telemedicine, somebody has to be physically present also. So is there merit in trying to bring about quick courses for them?
See, basically, the early detection helps the oncologist rather than anybody else. The reason being, telling a patient that the cancer is diagnosed at a very late stage and I have nothing much to do for you. Compared to this, if the patient is detected the breast cancer at an early stage, we can say that don't worry, we can offer you better treatment, curative treatment, and that too, you don't have to go for a mastectomy. We can offer you without causing any damage to your body structure. So these words are giving much comfort to the treating oncologist as well. So I feel that the screening programs are helping the oncologists. So all the oncologists who are, though they are less in number, they should be motivated in for doing all sort of social service, and they should be periodically communicated, and there should be a central committee, say something like Ayushman Bharat team. They can say that you do this many awareness program or this many screening programs, you will be recognized nationally or something like that. So that will be a motivation.
Recognition and reward. So
Reward.
yeah,
You
I
can
think
get,
that's a very,
yeah.
very important and interesting point, because generally we always look at the solution of saying, okay, we need some more people in this, but you're saying it's far more important to have those screening pieces in place to be able to solve the problem vis-a-vis the doctors. That can happen. It's not a big deal, but it is more important on, so focus on screening, 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 and funding is there. So let us organize how we facilitate the administration at the district level to make this happen. So thank you so much for what I would say absolutely insightful, practical answers to the problem, because generally in policy it's always 50,000 feet above and 10,000 gets left behind. So at least I've had a great conversation with you, and I look forward to having many more interactions like this with you. Thank you so much, Dr. Warrior.
Me too, and we have good, very good interaction and very good points we discussed. And once again, I thank you and congratulate you for putting up all these questions. And the last word from me is optimal utilization of resources. Thank you so much.
Thank you. Thank you. Thank you so much. Over to you, Khushbu.